Our next speaker will be helping us with, to understand the dietary nutrition, the impact of the diet and nutrition, and diabetes in the transplant population. Ms. Diane Pearson, welcome. Diane is a registered nurse. She's a certified diabetic educator. She works closely with our team in the outpatient clinics and in-house upon consent to follow up on all the diabetic-related issues and diabetes education in outpatient population and many more. So I will leave the floor for Diane here, and welcome. See you.
I'm thrilled that he didn't mispronounce my name like there was someone else that had it one time. Dying Pearson. Bad name for a nurse. Bad name for a nurse. Anyway, I want to tell you a little transplant story myself. It's pretty amazing when you get that call that the organ is ready for you. When you've waited for so long and tried to get your weight down, done this, done that. It's really different when you get the other call, which is, may we have the organs of your beloved. And I just want to tell you, 5 years ago, that call came to my home at 9 o'clock at night. It wasn't my husband, but it was his best friend, his best brother. And the three brothers were together for once. They couldn't get together here in San Diego enough, but they got together to have a weekend of fun in Arizona, where my husband was working at the time in construction. And they had all been racers as kids. They raced motorcycles, and now they were into cars, for heaven's sakes. I mean, little boys, they just never really grew up, but they had a blast with it. They were just on go-karts. And this younger brother to my husband, they were all on the track. He went around the track in front of my husband. They were all laughing, having a great time, all in full regalia and gear, as they should have been. And all of a sudden, this one, Kurt, pulled off to the side and ran into the hay bale. And he stopped. My husband thought, that is not good driving. You know, that's not what Kurt would do. He got out, he went over to him and found him slumped. They didn't really do a good autopsy over in Arizona, unfortunately, but some good things did come out of it. We think he had either an aneurysm or the aorta just exploded. It wasn't on impact either. We don't really know exactly what happened, but he died immediately. They tried to do CPR. The two brothers and another best friend did CPR on him. The ambulance didn't get there for 45 minutes. He was probably dead right away. The call I got was at 5 to 9 on that summer evening, and it was, oh my God, honey, my brother died, and they want his eyes. They want his heart. They want his skin. What do I do? What do I do? He said, we were just on the track an hour and a half ago together laughing. It's a weird call, wouldn't you say? It's a very weird call. But it's a necessary call. My amazing husband pulled himself together, and I supported him to say yes, yes. Give everything. What would Kurt have wanted? The only thing I want to do is meet whoever got his heart. I want to see if it's a guy, number one, and I want to see if he has that mullet haircut that my brother-in-law used to have that we hated. He was a good-looking guy, but he had a mullet haircut. And you know, I always have wondered about that, if people absorb some of the spirit of the person who donated the organs. So anyway, we think about transplant very fondly at our house, believe it or not. It's a good thing. And we're happy that Kurt could give and give again and again and again. I didn't know I was going to talk about that, but I had some extra time, so there we are. Okay, so I really want to talk about hyperglycemia and diabetes with transplant patients. I'm a diabetes educator, and I'm so fortunate that I and Brittany Sorensis, my partner, as an educator, get to go throughout the hospital. I do have one other question. Who's taking care of 11th floor? No, I mean, there's a lot of you here. That's awesome. That is so good. So we see lots of diabetes up there, don't we? So I have some particular information about NODAT, which is new onset of diabetes after transplant. That's the official name. You've probably heard of it before. And what is really the incidence of this occurring? I mean, you think about these people and what they've been through. Diabetes looks pretty small to them when they're going for that organ. You know, it's just like my life is going to be different. I'm going to get to live. At least I get a chance. They go through everything. They get on the steroids. Sugar starts going up, and then they hear they have diabetes. So that can be kind of scary. And it doesn't look so bad. Diabetes doesn't look so big in the beginning, but it starts looking bigger when the patient is outpatient or going out and having to learn from me and the nurses what diabetes is and what they're going to need to do. So here's the incidences with the different transplantations. Kidney, I've seen 25 to 50%. In this hospital, 1/2 of the people that leave with a kidney transplant leave on insulin. Okay, so does that mean they have diabetes? I want you to have this answer if you get no other answer or information from me. No, that does not mean that they have diabetes. They may just have hyperglycemia from the steroids and the immunosuppressants that they're on. All right, so when you see people with a meter and with insulin, that does not mean that they have diabetes. It means they have hyperglycemia, and it behooves you to check out what their diagnoses really are. It may even take a year before we know, as their medications are tapered to a lower level, and we see if the pancreas takes over again. So you can see where the higher risk is: African Americans, Hispanics, older age. Sorry about that, I just turned 60, so I'm kind of like older age, yeah, right, over 60. Male, pre-diabetes, familial gene for diabetes, really, obesity, and if they receive a donor from cadaver, higher risk. So there are possibilities, though, to avoid diabetes or prevent it, and we're trying to get at that end of things. You know, prevention instead of treatment. And the way we can modify things are just the way we modify for pre-diabetes. Decrease your weight, exercise more, get more muscle mass. You can't change who you came from, what your race is, but you can change some of these other things. There are centers that use less steroids also. They go up slower, they use less, and that may be one of their selling points. So hyperglycemia and diabetes. Okay, so I put a slash because I want you to think of them as separate. They have the same outcome, or they might look the same, a higher sugar. If the sugar stays high, there's going to be complications, there's going to be problems. Healing isn't as good. The graft doesn't take as well. More infections, all of that. They don't need that. So we need to think the hyperglycemia is what is the same between the two, but they might not have diabetes. So what are the things we're going to do? Right medication, right food, exercise, and stress and infection control. Well, you know, they don't want to exercise a lot right after a transplantation. I mean, a lot of times you have quite a design on your abdomen or in your back or down the front of you, and you just don't really feel like going out running a marathon. We're going to look at the other two while we're inpatient, and that is right medication and right food. So steroids and some of the immunosuppressants, as I was saying, are the things that interfere with the pancreas working as it should and bringing the blood sugar down. The immunosuppressants work more, and we really don't know exactly what they do. Not exactly. We have our theories, we have research. We think they decrease the amount of insulin that is actually made. The steroids, on the other hand, cause insulin resistance. So if you're making insulin, your body is just, these steroids are just fighting that insulin. So you can see as there's a taper, there's less of that fighting, internal fighting going on, and the sugar comes down. When a patient is immunocompromised, as you know, there's an increased risk of infection, and when a person gets an infection, the blood sugar goes up. It's this terrible wheel that goes around and around. So we want to keep the blood sugar down so that the patient can heal just absolutely as well as possible, and so that the higher sugar doesn't feed more infection. This is just the difference. One more time, when you see a high blood sugar, is it high blood sugar, is it diabetes? You know, honestly, sometimes you just cannot tell. Did you have it before? Is somebody in your family have diabetes? Oh yes, my mother and my father have it, and I'm a large African American. Wow, we've got some risk factors there, but I was never diagnosed. Wow, her blood sugar is regularly running over 250, and she had a liver transplant. Their sugars tend to run lower than the kidney transplants, a little different medication line. I'm thinking she might have pre-diabetes. You can just start thinking those things in your mind, okay? If there's more risks. You can talk to people about that too. Do you think you might have pre-diabetes? We look at A1Cs. Well, if there's a 12.5 A1C, we might say you appear to have diabetes. But if it's like 6.5 or even 7, and they've had blood transfusions, maybe that's changed their A1C, so we can't even tell what's really theirs and what isn't. You see? So it's a little difficult. Some people come to the outpatient transplant clinic saying, they told me I have diabetes, do I have it or not? And the doctors will say, no, you don't have diabetes. They say, but I'm checking my blood sugar, and the nurses had me watch this wonderful thing on diabetes on the 11th floor, the 6 West, or the different floors where it may be. And so I thought I had diabetes. So be careful. Yes, we do have a wonderful program that we're rolling out to the hospital that is internet-based, comes through, the patients can actually watch it at home also. It's about diabetes, and then the nurses do teach back questions. But nurses, please, and everyone else that works with transplant patients, be careful about diagnosing someone yourself with diabetes. We just don't know. That's kind of a surprise, isn't it? Okay, steroids. Wow. Steroids really do make a difference. So they cause general insulin resistance. In that person's case, by the way, why were they able to get steroids and not diabetes? They were building muscle mass. They're doing plenty of exercise while they're taking those steroids to bulk up. And the bulk is muscle, and then whatever they eat, if it's massive amounts of carbohydrates, it gets utilized extremely effectively. When you've got a lot of muscle, I mean, that's a bit much, I would say. He has a head too, by the way. I'm sorry, I just wanted you to get the idea of the muscles. When you have that much muscles, a large muscle mass, and you're lean, you have this muscle eating 24/7. Just feed me, feed me, feed me. I'm sleeping, but I'm eating sugar out of the bloodstream. Now, our transplant patients are, most of them don't look like this. I'm still looking for one, but the situation is a whole lot different. So their muscle mass is unable, and their exercise at that time is unable to keep up with moving sugar out of the blood and into the muscle. Lots of muscle mass, lots of exercise helps with that. So with steroids, they cause mostly postprandial increase in blood sugar. It's not so much the morning increase in blood sugar that you see a lot of times with people that have type 2 diabetes. They could even go to bed at a 180 and wake up with a 250 or 225. Why is that? Because the liver in the middle of the night is making extra sugar. It's very indiscreet, by the way. I mean, it shouldn't do that, but it does it. That's part of diabetes. However, look at your liver transplant patients. And you'll see pretty much of if it's going to be a high sugar, it's pretty much of the same sugar, between 50, 60 points. People with diabetes take steroids, you see really, really wacky, higher blood sugars. So just start looking at your glucose page and paying a little closer attention to that. So usually to treat this, it takes larger doses of regular insulin, Lispro, Novolog, any of those fast-acting insulins. Sometimes we use NPH too, and I'll show you that in just a minute, because you might go, you know, what kind of hospital is that? Those are old insulins, especially the regular and the NPH. There is a reason we use them, and when I show you the picture, we'll talk a little bit more about that. So the right meds for blood sugar control, what and when? So we look at the targets daily. In fact, believe it or not, we're finally getting our feet on the ground here, we two educators, Brittany and myself, and we're looking at the transplant list every single day, and we're looking at the blood sugars to see if we need to give the docs a call. We are on auto consult for those, which means we can call and say something without, hopefully without people being surprised. There isn't one cookie cutter patterned way for us to handle hyperglycemia. Each patient is completely different. Was their blood sugar way out of control before? Did they have other problems? Do they have diabetes? They don't have. Do they have pre-diabetes? What kind of steroids on them? What kind of transplant did they have? What are they doing? You know, I walked into a room the other day here on 11, and the woman that had the transplant the day before was, actually it was 2 days later, was standing up next to her bed, and I go, oh, please sit down. She goes, no, I feel fine. And I read her background. She was in her 50s, and she had worked her full-time job and didn't feel hemodialysis was a drawback for her. She'd go 3 days a week. She was fine. She was handling life. She had different genes. She was in great shape. I don't know what to say. She was doing great, and her diabetes looked better too. So you don't know. You just have to consider what kind of diabetes it is too. If this is a person with type 1 diabetes, that means they make no insulin, it's on the chart, you can see it, that person absolutely needs insulin. They probably need Lantus and a correction scale at least if they're NPO right after surgery. Why? Because if they, does anybody know why? What will happen with a person with type 1 diabetes if they don't get insulin? Starts with a D, K, A, yes, DKA, diabetic ketoacidosis, right? Very important. So they have got to have that insulin. Patients with type 2 make a little bit of insulin, so it kind of staves off that acidotic reaction. So they may or may not need insulin. Usually in this hospital, we try not to give anybody orals. I know sometimes they sneak in there just a little bit for one reason or another, but we try to put people mostly on insulin because we can manage that insulin. We know how long it's going to take to go into the body, to go out. You give somebody metformin or other medication, gee, are they metabolizing it? Do they have gastroparesis? Did it really go through? Did they have diarrhea and did that pill come out whole? No. Insulin is what, and are you looking for it? Now, hopefully not. You have other things to do. But we need control of the medication that we're giving people, just in case you wondered for your other patients, why are they not on the orals that completely controlled them before they came into the hospital? Well, this is the same reason we don't do it for transplants. And there's other reasons too. Some of those are toxic for organs, or can be. And you know, it's really touch and go, as you've heard. In the post-op times, people can have complications, build up fluid, infection, etc. So we want to watch what medication we give, and our choice is going to be insulin. So as I said before, it depends on which meds. Are we tapering? Are we going on the methylpred down from a really high dose progressively over the 5 days down to just a PO prednisone? If we are, we've got to change that insulin dose. So again, you just don't know where people are. Uh-oh, this guy needs more prednisone. Blood sugar's going to go up. He's having a problem. Looks like he's doing an early rejection. What are we going to do? More steroids? We're going to see an increase. It's not going to be same as the man across the hall that's had the exact same surgery on the same day. So what do we have to use? What's in our arsenal or our quiver of medications that we can use here in the hospital? And it's going to be the insulins. It's going to be the slow acting, which is Lantus, or also called Glargine, Detamir is another one that is very similar to the Lantus. It's just a different company makes it. We're going to use regular, as I said before. Regular insulin kind of hangs in the body a little longer, and I'll show you a picture of that in just a second. Lispro, we're going to use also, there's another one called Aspart or glulisine. So all those are our quicker acting insulins. We also sometimes use NPH. Why? And you'll see a slide of this. Why? It's because when a person takes, and I bet all of you can tell me this too, when a person takes a steroid or gets it IV, it's going to take a while to build up in their bloodstream, and you'll see over the next 6 to 12 hours an increase which slowly comes down. So we're going to want a medication that kind of hangs around in the system, right? Regular insulin does that, NPH does that. Sometimes we'll use Lispro, we'll get it down faster. It just depends. But I want you to expect that the blood sugar is going to go up if a person gets steroids. You might even see a pattern, something like this. Gee, can we tell if this person's getting steroids? Yeah. Or else they're eating a honking huge meal right there and it's going up, and the nurse is coming in and taking a blood sugar. But now when you go to the glucose page, which I hope you all do sometimes, if you go under your index and you go 3 categories down, you'll see glucose right there. Push on that button and you will see a nice graph of what your patient is doing. And if you hover to discover over each one of those dots, the time and the amount of blood sugar will come up for you. And then down below, we have if the patient is on steroids. You see the prednisone right here. You see the tabs, and you can kind of guess when that time was. Just look, going up above, looking at what time that high blood sugar occurred, you'll be able to figure out when that patient actually got it, and also the time will be down below. So I did want to mention that sometimes doctors would like to give more Lantus. They just say, hey, buddy, you're kind of high there. I mean, of course, I'm putting words in their mouth, but you're a little high there. If we give you a little more Lantus, you're not eating, by the way. So we're thinking you don't need any nutritional or fast acting. We're just going to give you more and more Lantus. Well, what do you think is going to happen with this patient with more and more Lantus on board? They're going to have a low, because look, they're coming back to baseline. They're coming back to 100. You put more Lantus on board and they're going to come back at a 58 that next morning. Yes, you might take the top off of this little mountain, but you're going to bottom out when that prednisone or that particular steroid is out of the system. We don't want to do that. So we really don't want to go too much up on the slow, long-lasting insulins. Instead, we want to say, okay, this prednisone, it isn't food, but it needs something to bring it down that's going to stay in the system for a while. And what insulins did I just say that might be? Yep, NPH, regular, and then sometimes we use Lispro too. Good. This is what they look like. Now, if you look back at that mountain, you want to have something that looks like a mountain that lasts about 6 hours. And which one is that? The regular. See the orange one? Yeah, that is why we give that old-fashioned medication. It's a good one. It covers the time. It goes out of the system slowly. We also happen to use that with tube feeds too for a very similar reason. We want it to last over a period of time. We give it about once every 6 hours. With steroids, it's going to be a little different. Maybe that's only given once a day. So we're going to want to give it at either the time coming up for food and the next meal too. I didn't repeat this when it was on the slide, but this is very important. And I intimated it, that really your high blood sugar with corticosteroids occurs after a person has eaten. after they have eaten in most cases. If they're NPO, you might see this too, but especially after they've eaten. So you can apply this to your other patients. Who's ever getting steroids, look at their after meal blood sugar the next meal. I get my steroid at 9 o'clock, I'm going to look at before noon. Is anything going on? Perhaps not. But before dinner, it's really high. Probably at about 2 o'clock, it was quite high. Okay, so it's a slow rise, but it's a continuous rise, and then it goes back down. So I don't want to apply the idea of insulin, insulin, insulin in the same dosages. I just want to hit that nice round hill that goes up. There's that hill. So instead of getting into this too much, because it might be kind of confusing, and especially if you're not used to doing this tabulation in your mind, I just want you to go away from this and not have death by PowerPoint here for a second. And I just want to tell you that what we try to do, once again, is look at that hill and apply the medications, their timing, and how much to what we need to accomplish. You're going to put on really good hiking boots if you're going up Mount Everest. You're going to bring a jacket too, and you're going to bring a bathing suit, just so that, you know, because you know you're going to get hot and cold. You're going to try and bring everything that you need. No, it's okay. In this case, we're going to want to prepare for that hill, and we're going to look at the size of it. Almost always, we're going to have less Lantus than we do of the fast-acting insulin that the person gets during the day. Now, I don't know if anybody remembers this, but usually when you look in general at how much insulin a patient is getting, like let's say they're getting 100 units a day. If I combine the fast-acting and the slow-acting, the basal and the bolus, they're getting 100 units. Really, a good balance, a good rule of thumb is 50% of it should be that slow-acting Lantus, and 50% of it should be fast-acting, divided into 3, especially if they're having 3 meals. When a person is on steroids, you're dealing with a different animal here. First of all, we only use 30 or 40% of that total amount of insulin on the slow-acting, because we know there's going to be a bounce up of this prednisone or this steroid. Okay, so just that's all that slide says, is that the balance is different when you have a transplant patient and you're using your insulins. You're going to be using less of the basal and more of the bolus, and you're going to shape the bolus numbers to go with the rise that the prednisone or the steroid causes. I should have just read it. It would have been shorter, huh? But the explanation, I really wanted you to see that. So now let's go on to the other thing that we can really do something about. So we talked about medications. We're not really looking at exercise because of what we talked about before too. People aren't real perky at that point. But what do we teach them in the hospital? And what do I teach them? And I teach everybody this that has had a transplant. They come to a pharmacy class, and at the very end, they let me come in and talk about carbohydrates. No, I don't tell them everything about blood sugar monitoring. You know, these people are wiped out. They're in their green gowns, sitting there with family members for an hour and a half listening for medications. Then I have to tell them something meaningful about their possibly having diabetes and an increase in blood sugar. One more thing. I don't know. Do you think very much is going to go in? I got to be pretty perky about it and pretty exciting, and you know, have some pictures and have some really good information. I've brought a little booklet for all of you, and it's the only one we give. It's just a small one, and we have it in Spanish and English, just English for everybody here today. It's just meal planning, but again, it says for people with diabetes. So please be sure that you tell them, now I know you don't have diabetes, but this is all the information you need to have about food. Really, don't get too excited about it. It's very thin. There's probably about 10 pages total. There's a little index in the back that helps you understand what we think a diabetes a diabetes portion size is, even though you don't have diabetes. Now I said even though we don't know if you have diabetes or if you'll have a high blood sugar, you can say any of those things. If you don't know, please at least say I'm not sure you have diabetes, but you might have high blood sugar from the medication. I also want to tell you really quickly what I say in my groups. And these are people that haven't yet been discharged. It's right after transplantation and before they are discharged. I say to the rest of the family members, this is how you should be eating also. This is how I should be eating also. This is how we all should be eating also. So people get the idea, you know, this isn't just for this patient, it's for everybody. You know that grand slam that you have of what equates to 4 servings of orange juice, 3 pancakes, 2 things of syrup, a little fruit bowl because you want to be healthy, a piece of rye toast because, whoa, you really love that stuff, slathered with butter. No carbs in the butter, by the way, but let's just have a heart attack over that one instead. And what else could we add there? Maybe put a Diet Coke in there too to feel good about yourself. All right, you've just had 8 or 9 servings of carbohydrate. And I always see people go like this in the chair, like one of the family members, because they're going, well, I like that. Well, let's see what we can change about that. You are not going to stop going out to IHOP or Denny's. We just want to teach you how to make better choices. What? I don't have to stop? You don't have to stop, you just have to fit it in. And so we start showing them what carbohydrates are, that they impact the blood sugar. They are the things that turn into blood sugar. So if you want to have less trouble with them, eat less of them. Don't go completely without them, they also give you energy. If you can get ones with fiber, that's even better. It'll clean out your system, make you a regular guy or gal, and decrease your possibilities of cancer. All that comes from fiber. You're just going to learn to eat better and you're going to be better. You have a new chance in your life. Take good care of your kidneys and keep your sugar down. So it's going to be fruit, milk, starch, and sugary stuff. Those are the carbohydrates. And then, of course, somebody always says, well, I like my sausage and my ham at Denny's too. I go, well, what do you think? Is that going to make your sugar go up? Well, no, you just said that's not in this group. You are right. So what does that do? Well, yeah, gives me higher blood pressure because those things have a lot of salt in them. It also has a lot of fat in it. Well, yeah, but I can't go without my bacon. Okay, have your bacon, but can you leave the sausage and the ham off? I mean, do you do this whole plate thing? Yeah, I can do that. Or I can just have a half, whatever it is. Most people are willing to change somewhat. We try and get them to be honest because when they leave, there's no one else out there to say anything to them. And they really are worried. They're really trying to do their best. And you know the other thing that steroids do is very often cause depression and mood swings. So you put that in with possibly having diabetes, sticking yourself 4 times a day, having to take 950 pills, etc., and feeling not too hot with a wound in your back, your side, or your lower abdomen. And you thinking, now why did I do this again? Did I really want to live like this? And then we restrict their food. So we try and fit things in that they just really love culturally, that they must have in one way or another. But most people really are willing to make different choices. What's free? Now, for anybody that wants to lose weight, this is the book for you too. Look at those free items in the back. And they're just a little example of what all the foods are, like eggplant. I know eggplant breaded in egg and crusty, cool stuff, deep fried with a nice sauce on the top. Well, yes, you're going to have some carbohydrates there. But just eggplant in general, sauteed, stir-fried in a little sesame seed oil, etc., is going to add no carbohydrates. Wait a minute, it says that vegetables have a little bit of carbohydrate in them. Well, yeah, they do. But if, for a serving of vegetables, like a half a cup to a cup, 5 grams of carbs, we don't even count it. All right? So, what should a balanced meal look like? Try and put half of the plate filled with vegetables. Oh, but your question is, but they have a lot of potassium in them. Yes, there are some things that you're not going to have to worry about anymore because you have new kidneys. There are some things you are going to have to worry about despite having new kidneys. We're going to need to have your blood checked on a regular basis, and then the dietitian that is outpatient is going to be the one that's going to come to you, and it's usually going to be Linda Raines. Is going to come to the patient and say, you know, your potassium is kind of high. We're going to need to cut out some of those tomatoes, the oranges that you're having. Yes, I know Diane said you could have 3 fruits a day and could have tons of vegetables, but we just got to cool it on this for a little while. We'll keep up with your potassium, we'll keep watching it, and we'll go from there. But many times they can start eating things they hadn't been able to eat for a long time. Nutrition label, I say don't look at anything except for the fiber. You want to get, the really good foods are 5 grams per serving, 5 grams of fiber or more, believe it or not. If it's less, that's okay. I want you to look at the total carbohydrates, especially if I have people counting carbs. The other questions a patient might have is, well, do I need to count carbohydrates, or do I just need to, you know, stay to 4 portions and learn what your portion size is? Like you're saying that a portion size according to diabetes size, which I don't have diabetes, but I have to look at their portion sizes. A portion of rice is 1/3 of a cup. Okay, so you're telling me I can have 3 to 4 portions a meal, and the answer is yes, that's right. That's all you need to do. You don't need to count carbs. Just have 4 portions, get used to what the portion sizes are. And it says right here, it just gives you an idea of what we recommend for men and for women and portion sizes. And you know, I do things like, okay, tortilla this size, 15 grams or 1 portion. And if I'm speaking to people only about portions, I'll say, that's a portion, this is a portion of bread, that's a fruit, that's a milk. Okay, so that's a cup, and this size for flat things. Those are all 1 portion. Oh, okay, so I can have, if I can have 4 portions at lunch, I could have 2 pieces of bread, I can have the turkey and vegetables. In fact, I'm going to pile my sandwich with tomatoes and avocado, and then I can have an orange on the side, right? And I'm still within range? Absolutely. Now, what are you going to have to drink with that? Well, I'd like a glass of milk. Okay? Brings you up? That's fine. Stay right there. Well, that's all I eat anyway. Did you want a little bit more? Well, yeah, could I saute some vegetables? What could I do? So that's how we talk about it. We talk about it very. So you can kind of look in the back of your book and see what portion sizes are, etc. So with monitoring, we just ask people to monitor pre-meal, breakfast, lunch, and dinner. Here are the guidelines. These are diabetes guidelines. Yes, this is very true, but what if a person doesn't have diabetes? These are people that are using steroids. We're using the diabetes guidelines for them. You see how people get mixed up about having diabetes or not? Because we keep using guidelines, etc. But it's okay. They've got a lot of other things to think about and be concerned about, so usually it doesn't get to be a big deal. I just would like to make it the strong point that we don't diagnose them. So, motivation. The worst thing is the chatterbox inside of a person's mind for us and for our transplant patients that keep saying, you'll never make it, you screwed up, one more time, you're a mess, why did I do this? What I say in my class, yes, my dietary class and my class about diabetes that's 15 minutes long, I talk about that voice. Because when you get so depressed, as I said before, that you don't even feel like eating, or you eat all the wrong stuff and you're hiding it from everybody because you just feel so down and out, and the only thing that feels good is to put something tasty in your mouth. When you feel that way, you get in trouble. You need to talk about it. And usually by that time, if people are sleeping or whatever in class, they wake up and they look at their significant others like, yes, I do feel moody, yes. And I encourage people to talk about it. That'd be a great time for a spiritual intervention too. And I do mention that. And I ask people to find out where their true strength is and to be present with that strength on a daily basis. So be creative. Think about what your motivator, your true motivator is. If it was those grandchildren in the beginning, but now you're feeling so bad you just want to die, I want you to put pictures of those grandkids up someplace. Keep that motivator in front of you. And I said one of the motivators that's very helpful is the Emmy program that we have, which approaches people from a scenario and picture video perspective, which is a way of learning and motivating too. So this is my last slide that's just talking about depression, watching for mood swings. What Eileen says over in transplant surgery is to tell people to expect bumps along the road. Not just bumps, but it's a bumpy road. Okay? You're gonna make it, but it's a bumpy road. If no one ever says that, then how scary is it for that patient to be going along and being thrown all around on this bumpy road and thinking it's never going to end, no one's ever been through this, I just feel like dying. I can't say it though because everybody around me is trying to be positive. People need to talk, families need to talk. There needs to be spiritual and emotional chat going on, or they're not going to take their insulin. They're not going to eat the right foods. You see, it is related to diabetes. It's related to the healing that you do in the units that you're on too. It's patient-centered, as the people from social work said. So just know that people may go home on oral diabetes medicines, glipizide. Maybe they don't have diabetes, but they're on glipizide. I know it's weird, but it's real. That's a way that we're handling their particular sugar. They may go off of it once they get to the clinic. They might go home on a combination of Lantus or Glargine, Detamir, one of those, and some orals during the day to take care of those spikes. They may go on something that you think is kind of strange, like why are they on this little dose here and this big dose there? Look at where they're taking their steroids. That'll give you a hint. Or maybe you just feel uncomfortable about it. If you are uncomfortable, ask the doctor. We all need to hold hands in this around and with the patient. If they're asking you, why am I on this stuff? I never had that before. In fact, I got a rash when I was, is this a sulfa drug? Yes, it is a sulfa drug. Oh, well, I've had this rash all over my stomach for 4 days, but it was the least of my concerns. Oh my goodness. So when a patient also feels that camaraderie with you and that you care to ask if there's any other questions, they will give you amazing information that will help them stay out of the hospital and start their new life successfully. So I wish you all luck and love with your patients and healing within for yourselves too. Please read the Carb book.